6 months to 1 year is a good time. So that is always FAQ that we always get, the frequently asked questions. So what is the time required? Time required is minimum 6 months to maximum 1 year. So depends on how much time you can give to your studies. Okay. So over to you, Dr. Dhanashree. Yeah. All
Thank
the
you,
best,
Dr.
everyone.
Yeah. Okay. So hello, good evening from my side. Okay. So today we start with, first of all, congratulations all of you for clearing your part one. Part one is very basics of the OG. All right. Now, when we go to part two, first of all, okay, why it's not moving? Got it. So part two is all about guidelines. Okay. It is said that part two is a little bit more difficult to pass as compared to the part one and part three. However, preparation for part two is very precise. It consists of a lot of guidelines which is published by the RCOG, out of which the most important ones are your green top guidelines. Then comes the NICE guidelines, then best paper practice, then there are SIPs, the BASH guidelines, the good practice points, FSRH, embrace guidelines, colposcopy, and the ESHRE. Now, this list seems unending, but out of all these guidelines which are listed over here, they can be pretty overwhelming. However, the green top guidelines are the most important guidelines along with the NICE guidelines. I want, when you're preparing for your MRCOG part 2, the green top guidelines and the NICE guidelines and the consent advices. Please remember, if you're just taking down the notes, whatever I say, duration for MRCOG part 2, because the portion is very vast. So the green top guidelines, the NICE guidelines, the consent advices, these are the three things which should be at the tip of your tongues, and it should be completely read. Okay. So you must know each and every point what is given in these three things. When it comes to your ESHRE, the colposcopy guidelines, the embrace, the FSRH guidelines, the good practice, the BASH, the scientific impact papers, make sure you are having a detail about it only till the executive summary. Okay, you don't need to go into the very much details, because every guideline of FSRH can be of 50 pages. Okay, same with embrace guidelines. So you must know that the details, the precise notes of all the rest of the guidelines are important. However, the green top guidelines, the NICE guidelines, and the consent advices, you must know word to word. Okay, now moving on to the next slide. Okay, next thing which comes with the RCOG is the TOG, or the OG, the obstetrics and the gynecologist papers. This is a magazine which is published by the RCOG. Okay, it is said that at least 5 years, the past 5 years, the TOG is published 4 times a year, every year. So that's going to be the 20, almost 5 4s are like 20 publications, last 20 publications, which you're going to go through it, read it in detail. Again, make notes. I want you to read the talk again just once, make the notes. Next time you revise the notes. Strategy is a e-learning platform. Whoever is a RCOG associate member, after passing part 1, they do a RCOG associate membership, and those people can access the strategy. Even if everybody is not able to access the strategy, there can be few of people in your group. You can combine together and you can share during your discussion. Of course, a few things from our side will also be there with the strategy e-learning platform. Okay, the next exam is coming up in July. So we are right now in February. So people who are planning to take an exam in July, they have 4 to 5 months, good months. So of course, they need a good planning, and you can go through the exam. Now, MRCOG Part 2 exam consists of 2 papers. Okay, each paper is of 3 hours duration. Okay, Part 1 will have 50 single best answers and 50 EMQs, the extended matching questions. And again, Part 2, the paper 2 will again have same 50 SBAs and 50 EMQs. Now, when when this format or SBS is very popular, it's very common, like choosing a single best answers. It is present in a lot of competitive exams. However, in EMQ format is a format in which the depth of your knowledge is tested. The RCOG recommends very specifically, at least in a paper of 180 minutes, give 70 minutes for your SBAs and 110 for EMQ. Believe me, EMQ is a work of practice. The more you practice, the more you're going to be able to get through the EMQ part. With our course, we are going to give you an authentic and precise guidelines. I'll just get through today's GTD, where you can understand what should be your approach towards doing the GTG guidelines, how you should read the GTG guidelines from EMQ and SBA point of view. Okay. Why the course is important? Because the MRCOG part 2 portion is very vast, as you just saw. Okay, you have to break down, it's like, breaking a full thing. You can't have the full thing all at once, so you have to break it into small parts, make the concise notes, work on it, revise, practice the questions, and then go ahead. All right. Of course, during your tenure of starting with the exam, like Mr. Ken just said, he would be liking to start in January, appearing for an exam in next January. In that 1 year, RCOG at times publishes newer guidelines, new nice guidelines, new talks. So you must be updated throughout your tenure in planning the entire part 2 or part 3 exam. All right. Okay. Okay. We are going to have weekly sessions. There's going to be a practice group. We are going to discuss questions from past papers, the recalls, and of course, we are going to tell you how to deal with the notes and how to apply the notes, the GTG notes, to solving your EMQs and SBAs. Okay. The ending line for any orientation for part 2 will definitely, you have to read the GTG. Only reading GTG does not help you crack the part 2. You must solve, you must practice, and practice maximum SBAs and EMQs. Okay. We wish you all the very best from our side towards your preparation for MRCOG part 2. Okay. Now I need to get out of this. Just give me 2 minutes. So I'm starting today with management of gestational trophoblastic disease. Okay, this is GTG guideline number 38. It was last updated in 2020. Prior to that, it was updated in 2010. Okay, less likely any update coming for it, but still, if at all it is there, we will update you. Okay. Okay. So now, GTD, 2 minutes. Huh? I just need to minimize that. Okay. So GTD, gestational trophoblastic disease, is a group of disorders. I have prepared this PowerPoint presentation in such a way that every slide, even if you do these slides, you will be able to answer 90 to 95% of all your GTD questions from all your practice groups or recalls. Okay. GTD is a very simple guideline. It comes in the module of early pregnancy care. Again, a very important guideline and an important module for scoring in part 2 MRCOG from SB and EMQ point of view. Okay, so let's begin. GTD is a group of disorders. I don't mind any of you, if you want to just ask any questions, or somebody does not understand, or if I'm going too fast for somebody, you can just raise your hands and I can help you out with that, or you can just we can just answer the query. Okay. Now, GTD is a group of disorders. They're divided into two parts: the pre-malignant ones, which has complete and partial mole, okay, also known as the hydatiform moles, and the malignant conditions, which are the placental site trophoblastic tumor, the epithelioid trophoblastic tumor, and the choriocarcinoma and invasive mole. Now, why this definition is important? Because it has a very simple SBA from this slide. GTD is gestational trophoblastic disease. What is GTN? Now, any evidence of persistence of GTD after the primary treatment of GTD, most commonly defined as a persistent elevation of human chorionic gonadotropins. I want all of you to have attention over here. So GTD is very different from GTN. GTN does not require any histological confirmation. It's a mere disorder where there is the elevation of HCG post any GTD. Okay. Now, the diagnosis of complete mole, partial mole, or typical PSN, PSTT, and ET does require histological confirmation. Why these two definitions are important? Because here we have the first question. Which of the following is not an example of gestational trophoblastic disease? Can anybody answer it? Hello? 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 Can anybody answer it?
I think it's either A or E. I'm not sure.
Okay. Okay. A or E? Why do you think it's E? Can we go back to the slide? The first slide?
It might be. I think it's A.
Yeah, correct. You're correct. You're absolutely correct. Okay. Because
I was doing process of elimination. That's why it takes me a little bit of time. That's why I think I need till January.
No. It's I think after this lecture, you'll understand how to approach. That's a good way to approach. See, in a SBA, it's a good way to approach the exclusion criteria. Okay. But with the EMQs, you must know the answer first, and then at least a part of the answer first, and then you can exclude. Okay. That's fine. You can use whatever technique you want. That's all fine. So you're right, Mr. Kens. It's chorioangioma because choriocarcinoma, complete mole, partial mole, placental site, trophoblastic tumor, all of them come under GTG. We can go back to the first slide. Okay. Now does it become more clearer why the answer is chorioangioma?
Yes. Thank you.
Yeah. Okay. Anybody else have any doubts? Very simple. I want these two definitions just fixed up in your mind. And any SBA, it's like a very simple SBA. Should not miss the point on this SBA. Okay. Okay. Now, simple symptoms and signs of molar pregnancy. I've written down a lot of symptoms over there. Now, the first one is irregular vaginal bleeding. It's the most common symptom, 60%. A positive pregnancy test, USG, evidence of any mole, either complete or partial. The rest of the symptoms are hyperemesis, excessive uterine enlargement, hypothyroidism, early onset preeclampsia. Now, early onset preeclampsia and early onset preeclampsia is one thing which can come as a leading part in your EMQ or SBA, where you must start thinking about GTD. That's the reason I've just highlighted it over here. The last three symptoms, the hemoptysis, acute respiratory failure, seizures, they are all signs of metastasis. At times, you just get that the patient had got GTD 6 months back. Suddenly, she comes with hemoptysis, acute respiratory failure, seizures, and then some of the positive pregnancy test or a USG sign. So then your mind is going to work towards GTN. That's why the slide of symptoms and signs of malar pregnancy becomes important. Okay, you must remember not all of them, but maximum, so that when a clinical scenario is given to you, your mind gets diverted towards the GTD and GTN, because this is just one topic we are doing right now. By the end, you're through with your MRCOG part 2 entire curriculum. There are going to be multiple clinical scenarios from different GTGs, and you must remember what is more significant for this GTD kind of complex. Okay. Now, next question. What is the most common symptom in women who develop GTD after miscarriage? Anybody? Simple question. Anybody? Come on.
Vaginal bleeding.
Of course. Very good. Now, the only thing which is over here. What is the most common symptom? I don't know. Okay. The most common symptom in any GTD, whether it comes after a miscarriage or after anything else, even after a partial mole or complete mole, is always going to be vaginal bleeding. This is just something, this part of the after miscarriage is just something for a distraction. Okay, this is one of the SBAs in your practice box. Okay, this was easy. Next. Now, this table is very, very important for your SBA, for your EMQs also. A lot of questions come from this slide. So I want this slide, prepare it the way you want. You can yourself go through GTG, but you must have something concise like this slide in your notes. Okay. Now, first, the complete mole. The karyotype is diploid. Why the karyotype is diploid? Remember this. Okay. The complete mole, maximum of the times, the 75 to 80%, there is duplication of single sperm following fertilization of empty ovum. When you say an empty ovum, that means it is just OO. It's not XO, it's just OO. And dispermic fertilization of empty ovum. So it can either be duplication, a single sperm, which is of karyotype X or karyotype Y, is going and fertilizing the empty ovum where the karyotype is 0, 0. There is no karyotype. There is no X, no Y. Why it is important? Because there is a slide coming up, which is one of your practice books against EMQ, and we'll be able to solve it after understanding this concept. Okay. So when I'm saying duplication of single sperm following fertilization of empty ovum, 0, 0, nothing. Okay. Now move on to the next part of it where we are talking about the partial mole. Now partial mole is triploid. Okay. Why it is triploid? Because two sets of paternal and one set of maternal. Okay. Why? So it's dispermic fertilization of an ovum. So it's either going to be XX with X of the ovum. It can be XY with the X of ovum. Okay. Occasionally, that is 10 to 15% times, it's going to be a tetraploid or a mosaic partial mole. Okay. Is this concept clear? Anybody? Is this concept
Yes,
clear?
yes,
Yeah.
yes.
Yeah. Okay. Now, so very simple, this diagram. Again, very simple, which we have learned in our OG residency. In complete mole, there is no evidence of any fetal tissue. In partial mole, there is fetal RBC and fetal tissue. Okay. Again, USG signs, complete mole, polypoidal mass at 5 to 7 weeks, and no GSAC, thickened cystic spaces of villus tissues. This is just good to know part. But what is more important is definitely this. Okay. Definitely this. The most important in your chart, which is supposed to give you a lot of questions. All right. Again, the last part, enlarged for partial mole, it is enlarged placenta with cystic changes, empty sac or a delayed miscarriage. And again, the ratio of transfers to AP of the GSAC is more than 1:1.5. This is good to know. USG markers is good to know. Now let's go on to the next slide. Okay. Oh, this is there. It's not going. Okay, it's this one. Okay, the next slide. Again, as we had just discussed prior, for any GTD, the diagnosis, the definitive diagnosis will always be histopathology. So what are the features of histopathological for complete mole? First of all, absence of fetal tissue, extensive hydropic changes to the villi, excess trophoblast proliferation, presence in the partial mole, it will be always presence of fetal tissue, focal hydropic changes to the villi, and some excess trophoblast proliferation. The last, immunohistochemistry is a P57 marker, which is present in partial mole. I always used to remember P57 and then partial mole. So it is P57 is present in partial mole. Okay. These are a few things to remember in short, what like immunohistochemistry markers, etc. Okay. Clear? Any questions? Any doubts?
No.
No? Correct. Okay, now this is one SBA. Okay, just read it. Try to attempt to solve it. I'm all yours. Okay, yeah. Anybody?
A. Complete moles arise as a consequence of diaspermic fertilization of an empty ovum.
Okay. Anybody else want to attempt? Varsha madam?
Yes.
Yes. So B is not correct. Okay. Complete moles show evidence of mature fetal cell. Absolutely wrong. Can we correct it? What is the correct answer for this? It should be partial moles.
Partial.
So, yeah. Then, partial moles occur rarely due to dispermic fertilization of an ovum. Is it so?
Partial moles are generally
due to,
tetraploid.
yeah. Partial. Yeah. You want to correct your answer?
Partial moles occur rarely due to dispermic fertilization of an ovum. Yes.
Should we go back to the slide? Just see the percentages over here. Okay. And then I'm taking you back to the slide, the previous slide, which I told you. Okay. Let's go and see how we can, what changes can be done. Okay. Now tell me.
75 to 80% is duplication of single sperm following.
Correct. Yes.
But so the duplication occurs in 75 to 80%.
Correct.
While the dispermic fertilization is only 20 to 25%. So it's
Correct.
the other way.
Yes, it's the other way. Next part. 90%
Partial moles
is
as 90% are triploid.
correct.
So it's one paternal, two sets of paternal with one set of maternal.
Maternal.
Okay, got it.
Okay, now do you want to correct your answer? Now tell me what's the answer.
I don't know why it becomes confusing when you see the question.
Okay, yeah, because there's a lot of information. So let's correct it. Let's do it all together. Complete moles, 75 to 80% arise as a consequence of dispermic fertilization of empty ovum. No, this is duplication.
Duplication.
Correct.
Duplication.
Okay. Okay, so this one is incorrect. Correct?
Correct.
Then complete moles show evidence of mature fetal red blood cells.
No, that will be partial. Partial
Correct.
moles.
Correct. Partial moles occur rarely due to dispermic fertilization of an ovum.
Yeah, that's correct.
No, rarely, madam.
Rarely.
Rarely means no, rarely. 90% of them occur due to dispermic fertilization.
90% occur. Yeah, partial moles.
Yeah, because if there is a dispermic fertilization of an ovum, the karyotype is going to be a triploid karyotype. Right karyotype is 90%. Okay. Now, some complete moles arise after duplication of single sperm. No, it's most of them.
No, it is most of 90. It is 70 to 80%.
Correct. And then what is the last option?
10% of partial moles represent. That is the correct answer.
Correct. Now does it become easy?
Yes. I mean, we have to read every word.
Exactly. The thing is that the PPT is made in such a way that even if you go through the PPT, as I said, every word is important. Make notes also in that way, like parallelly. Do your GTG, go through your practice books, again come back to the GTG, understand which is going to be a SBA, which is going to be an EMQ, and again read it. That's how Again, repeat. That's how the GTG will be mastered. Okay? Everybody clear? Any doubts?
Got it.
Got it? Okay.
Yes.
Yeah. All right. Okay. This is the next question. Most likely karyotype. Now, in an EMQ, this is the EMQ format where you're having almost 12 options. Okay. And you're supposed to select the best one. Okay. A woman presents with hyperemesis and bleeding to the EPC unit. USG signs of complete mole and confirmed with the HP after evacuation. Okay, so they are clearly telling us, again, this is from, I think, Tahir Muhammad, one of your EMQ books. Okay, so they are clearly telling us this is a complete mole. They have confirmed it with HP also. Now, always read the first part of the EMQ and then the what is the leading question. Okay, it's always going to, the EMQ is always going to have a stem and then the last leading question. Every word always given in an EMQ is of certain significance. Nothing is given just for the sake of it in an EMQ. Okay, always remember that when you're solving EMQs. Now, what is the karyotype of the sperm that fertilized the oocyte? Okay, anybody wants to try?
E, 46XY.
Or D.
Why E or D? How can sperms be diploid?
Oh,
What is the karyotype of a sperm?
20. So it will be 23Y.
Either it is 23X or it can be 23Y.
23Y. But here
Okay.
the complete mole is generally 46XYY. So it has to be 23Y.
Evacuation. Why is scared?
Why it is 46YY?
Oh no, it's the sperm itself will be 23
No, it will be dispermic.
XY.
Yes, you are correct, madam. But sperm karyotype can be 23X or 23Y. If the X chromosome, 23X sperm fertilizes, or two 23X sperms are going to fertilize an empty ovum, you're still going to get 46XX. Okay. Are you getting my point?
They are asking karyotype of the sperm.
Correct. So everything else is cancelled. You have only two options, 23X and 23Y.
The oocyte is going to be OO.
0, 0.
0, 0.
There is
So
nothing, null.
nil. So
We are not talking about the oocyte any which ways, madam. What is the karyotype of the sperm that is fertilize the oocyte? It can be 23X, it can be 23Y. The karyotype of the sperm can be 23X or 23Y.
so it will be 23Y only.
It can be 23Y, correct? And it can be 23X. But now, is everybody clear why we have come to those answers and why not 46,
Yeah.
45, 40? So,
Yes, it's a
Dr. Ken,
haploid. We are talking of a haploid sperm.
exactly. So in the EMQ, even if you go by your technique where you're excluding, Dr. Ken's, all the options, you are just left with two options. So in an EMQ, even if you go by exclusion, at least you must know a part of the answer. Okay, that is what solving an EMQ is. Okay, you're right. You're on the right track. Dr. Vaisha ma'am, you're on the right track. It is either 23X or 23Y. Now, the answer, however, this is not given in your GTG, but according to the sources, 23YY, 2YY is said to be incompatible with life. Okay. So if you have only a Y chromosome fertilizing the empty ovum, any which ways, it is not going to convert into anything. It's like null, okay? Because YY is a chromosome type which is incompatible with life. This is a hard-hitting thing, but it's given in all the sources of your practice books. Just remember, good to know. It's not must know, it's just good to know. Okay? Okay, clear? So that's why the
Okay.
answer becomes 23x. Sorry, that's why the answer becomes 23x. Okay?
Okay.
Okay? Okay. Okay. Now, the next part. A woman attends routine dating scan at 12 weeks. USG signs of enlarged placenta with cystic spaces and small fetus. Evacuation confirms partial mole. What's more likely karyotype? Now, here they are asking the karyotype of the
Character
partial
of the
mole.
partial mole.
Correct. Now tell me which options are you looking at?
The 69 one.
Correct. Absolutely correct.
So
Hmm.
it has to be.
Wait on. I will give you another table. Then you can answer it perfectly. Sorry, I give you the answer only. I'm sorry. Yeah. So the sources say 69, 69, 69. So again, the rest A to J options are nullified for this question. 69XXY. 70% of the moles have the karyotype, partial moles have the karyotype 69XXY. Again, not given in your GTG, but this is again good to know, information good to know, sourced from one of your practice books. Okay, just remember this table. That's why I've put it over here. So you just remember this slide when you're revising. Just revise it this way so you remember. Okay, are you clear now? As far as the karyotype of the sperm, the complete mole, and partial mole goes. Hello?
Yes.
Clear? Any doubts?
Yes. No.
Any doubts?
Got it.
Got it? Clear? This is not going to come this complicated, but it is one of the most difficult because the sources are limited, not given in your GTG. Just remember this table. It's going to be 69XXY, which is the most common karyotype of the partial mole. Okay. And later on, it is 69XXX and 69XYY. Okay. Okay. Let's go to the next question. Now, this is a slide of all the incidences. I have compiled it all together. I would suggest, I would rather recommend whenever you're doing any GTG, keep a small diary, or when you're preparing for part 2, keep a very small diary in which you keep on writing the incidences. Okay, so you can read those incidences almost like every day, scan through it. If you're going to read every day for 5 months, you're going to remember it on the very last day. Okay, now the most important incidences from this GTG is, first of all, GTD incidence in UK. It's 1 in 714. Again, one important SBA. Then a chemo rate for the complete mole, 13 to 16%. Chemo rate for partial mole, 0.5 to 1%. And if there is one mole, the recurrence of one mole, recurrence after one mole, 1 in 80. Okay, this is again important SBAs. Okay, just compile all your incidences on one page, keep on marking. That's why I said do the GTG, go back to the solving questions, then you would know which incidences are coming as an SBAs or EMQs. Go back to GTG again and then mark those incidences. Ki, haan, this is the probable question. That's how you will know by the end of it which incidences in a particular GTG is of utmost importance. Otherwise, in this GTG itself, you have 15 incidences. All 15 incidences, it is humanly not possible to remember so much thing. But if you know which are the important ones, you can always have them jotted down and then it becomes easy. Okay. Okay, clear this slide, clear, very simple slide. Again, compiled all together for you. Okay. So one of part of our GTGs would be, you will always get a slide like this where all the incidences are all compiled together. Okay. Got it? Should I move? Moving. Okay. Now, the treatment for complete mole and partial mole. Again, for complete mole, it is always surgical evacuation, irrespective of the uterine size. Surgical evacuation is preferred as compared to the medical one, because in medical management of complete mole, there is higher risk of developing GTN or requiring chemo. Because I'll share another the next slide to explain this. If it's a partial mole, always remember, if it is a small pregnancy, the gestational age is small, like 15 weeks. Okay, you will go for surgery. If it is more, it's going to be medical management. Okay. No offense of the fetal. GTG says that if the fetal parts are deterring the surgical management, you would choose the medical management. That's what the GTG says. But 15 weeks is at the time where it becomes absolutely difficult to have a surgical evacuation. Now, talking about anti-D, a scenario is given where you have somebody undergoing a surgical evacuation for a molar pregnancy, and they say that the HP is the histopathology is complete mole. Now, why? Who can tell me why, if it's a complete mole, you don't require anti-D, and if it's a partial mole, you require an anti-D? Who can tell me that?
There is no sensitization. There's no
Why there is no?
allergy because there's no fetus.
Perfect. Absolutely correct. Yeah, absolutely perfect. Exactly. Because there are no fetal cells, you don't require any anti-D. In partial mole, because there are fetal red blood cells, you will require anti-D. Now, what to do if no histopath is given? What do we do when no histopath is given? If no histopath is given, we will give anti-D.
Give anti-D.
Yes, it's like a benefit of doubt, because we have to give anti-D in for 72 hours. At times, histopath may not be available for weeks altogether. Okay, so we give anti-D. Again, an important SBA, simple SBA, but can cause confusion, because when you will be doing MRCOG part 2, the final exam, you must remember anti-D given post a miscarriage, anti-D given post complete mole, anti-D given post partial mole, anti-D given post surgical management of ectopic, anti-D given over expectant management of ectopic, anti-D given post medical management of ectopic. So this is going to cause confusion. Okay, so again, very important, once and for all, just remember this much, you're all set. Okay, who can attempt this question? Anybody?
He confirms in terms of anti, what is the most appropriate management? Anti-D is not required.
C.
C.
Correct. 1 minute. Correct. You're correct. And okay. Now the treatment part, simple. Suction curettage is the method of choice for removal of complete molar pregnancies. Now, whatever sentences I have written over here, you might get a long SBA which says which of the following is correct, which of the following is incorrect. So please do a concise your own notes of this treatment part for the GTG, treatment management of complete mole. Okay. Now, ultrasound guidance during removal and curettage may be of use to minimize the chances of perforation and to ensure that as much tissue as possible is removed. Suction curettage is the method of choice for removal of partial mole pregnancies, except when the size of fetal parts deters the use of suction and curettage, and then medical removal can be used. They have not mentioned 15 weeks, but we take it as 15 weeks because after 15 weeks, the fetal parts will start hindering with your surgical management. Okay. Now, this is one thing which is again important. Okay. Oxytocin infusion, whether to be used in a surgical evacuation of the complete mole or no. So, what your GTG says, this is kind of an exact excerpt from your GTG. Excessive vaginal bleeding can be associated with surgical management of molar pregnancy. There is a theoretical concern over the routine use of oxytocic agents, including ergometrin and misoprostol, because of the potential to embolize and disseminate the trophoblastic tissue through the venous system. This is known to occur even in normal pregnancies, especially when uterine activities increase. Example, placental abruption. The contraction of the myometrium may force tissue into the venous spaces at the site of placental bed. This dissemination of tissue may lead to profound deterioration with embolic and metastatic disease occurring in the lungs. Now, the last sentence, which says, in the event of life-threatening hemorrhage or ongoing bleeding, oxytocin infusions may be used. Now, in all your RCOG publications, you will always have use this, consider this may be used. Okay. So you might get a scenario in which, or an EMQ question in which they are doing a surgical evacuation, the patient is all fine and all, and then the options will be use syntocin or use oxytocin, or at times it can be a life-threatening hemorrhage. And again, the option somewhere would be that oxytocic infusions may be used, or consider the use of oxytocic infusions. That's why this paragraph is important. Okay, in SBA or an EMQ question, wherever you are having patient is having life-threatening hemorrhage, patient is hemodynamically unstable due to ongoing bleeding. Okay, all these words will point you towards the use of oxytocins in the management of surgical evacuation of molar pregnancy. Otherwise, oxytocin infusions are not to be used in surgical management of molar pregnancy. Search for these words in your questions: life-threatening hemorrhage, ongoing bleeding, hemodynamically unstable. When you have these three pointers, any one of these three pointers, that's the when you think about oxytocin infusions in surgical evacuation of molar pregnancy. Am I clear about this slide?
Yes.
Yeah. Okay. Now, in what circumstances should a repeat surgical removal be indicated? Now, a few slides which are coming up, they are not explicitly your SBA or EMQ questions, but they are just clinical scenarios which might be presented to you in a question format. Okay, so just concentrate again. Good to know. Okay, not must know category for me, but good to know. Okay, now urgent surgical management for the woman who is experiencing heavy or persistent vaginal bleeding causing acute hemodynamic compromise, particularly in the presence of retained pregnancy tissue on ultrasound. This is the scenario in which you are going to immediately consider surgical removal, which is going to be a repeat surgical removal after first surgical evacuation of the molar pregnancy. Okay. Now, if at all the clinical scenario says that patient came who is having persistent vaginal bleeding, she is hemodynamically stable, and on the USG, there is retained pregnancy tissue after a surgical evacuation of a complete or a partial mole. Now, in that kind of scenario, please do not choose the surgical repeat removal. You're going to choose, you're going to refer her to a GTD referral center. Okay, because that's what your GTG is saying. Now, all of you are consultants practicing OGs in your respective fields, but MRCOG Part 2 exam are for the ST trainees. They give it at, I think, ST 5 or 6. So at times they do have at the back of your mind, always remember this whenever you're solving any MRCOG Part 2 paper, any AMQs, any SBS, even if you know what is the next thing to do, and if there is a roadblock which says referral, okay, keep it at the back of your mind. At that level, referral to a center is expected out of the training or the ST5 level or the ST6 level. Always remember that. Okay, always have that at the back of your mind. So coming back to this scenario, if you're having somebody, as I just said, heavy persistent vaginal bleeding causing acute hemodynamic compromise, you're going to have repeat surgical removal. But if the patient is hemodynamically stable, she's having persistent vaginal bleeding, hemodynamically stable, there is presence of retained pregnancy tissue on ultrasound, you're going to select GTD referral center. Okay, clear? Clear? Any doubts in this? Going on to the next. Okay. Okay. Now, the histological should pregnancy, now again an important scenario, should pregnancy tissue from all miscarriages be examined histologically? Now this as I said, this coming few slides are just good to know part of your GTG. Less likely questions are from this part, but still you must know what are the recommendations. The histological assessment of material obtained from medical or surgical management of all miscarriages is recommended to exclude trophoblastic neoplasia if no fetal parts are identified at any stage of pregnancy. Women who receive care for a miscarriage should be recommended to do a urine pregnancy test 3 weeks after the miscarriage. Again, this is important. This point is important when you're doing a follow-up of a miscarriage, which we will be doing in the module of EPC, where we are going to see what are the nice guidelines for miscarriage. But this is just mentioned in this GTG. Okay. Now, As GTD can be difficult to recognize at the time of miscarriage, it is recommended that either all material obtained from the medical or surgical management of miscarriage be sent to pathology. If no tissue has been sent to pathology, a pregnancy test should be carried out 3 weeks after the miscarriage. If it is still positive, the serum level should be tracked to ensure that the level is falling. And if not, an ultrasound is arranged to look for further pregnancy tissue. Now, this part is one, again, an EMQ would be coming ahead where it addresses this scenario where you have post a complete or a mole, there is surgical evacuation, the patient has very high um, HCG, and then what is the next step to do? Okay, this is one of your EMQs which is coming. Okay, so remember this slide. Now, the incidence of GTD unrecognized prior to removal is 2.7%, again listed in the incidences slide. Or again, a slide which tells which we just discussed. If the material is not stand, we do a UPT after 3 weeks of miscarriage. If it is positive, we are going to arrange for USG. What are we looking for in the USG? Anybody? Are we looking for only GTD or we are looking for something else?
GTN, basically, development of GTN.
Okay, yes, we are looking for that. What else?
Any retained products only, retained products of conception.
Okay, fine. Okay, the question will be modified UPD after 3 weeks of miscarriage, and if positive, arrange for a USG. Fine. Okay. Next. Should pregnancy tissue be sent for examination after an abortion? Now, there are two parts. There is no need to routinely send pregnancy tissue for histopathology examination following therapeutic abortion, provided that the fetal parts have been identified at the time of surgical abortion or prior on ultrasound examination. Women who undergo medical abortion should be recommended, again, this is from your NICE guidelines, recommended to do a urine pregnancy test 3 weeks after the procedure. Risk of GTN developing after confirmed therapeutic abortion. The rate is 1 in 20,000. Just good to know. Slide. Now, how should women with elevated HCG after a possible pregnancy event be managed? Referral to a GTD center should be considered for all women with a persistently elevated HCG, either after an ectopic has been excluded or after 2 consecutive treatments with methotrexate for a pregnancy of unknown location. Now, this slide, I've just mentioned it over here. It's because if you have a PUL, again, we'll be doing it in the ectopic part. We'll again come back to this slide. But just remember, you have, if there is an elevated HCG after a possible pregnancy event, referral to GTD center would be one of the options which you're looking for. Okay. Next. Which women should be investigated for GTN after a non-molar pregnancy? Again, GTN can develop after a miscarriage, therapeutic abortion, and term pregnancy. It can also develop after a GTD also. So understand this, GTN is not only after molar, it can also happen after a non-molar. It is uncommon, less than 1% for GTN to develop in women who have had a normal HCG, urine, or serum level within 8 weeks of removal of a molar pregnancy. Now, any woman who develops persistent vaginal bleeding after a pregnancy event is at risk of having GTN. A urine test should be performed in all cases of persistent or irregular vaginal bleeding lasting more than 8 weeks after a pregnancy event. Also, there are other symptoms like dyspnea, hemoptysis, new onset of seizures or paralysis that can occur very rarely, but still. Biopsy of any vaginal wall is not recommended at all. Okay, for GTN, again, GTN is not diagnosed with histopathology. GTN is diagnosed on. GTN is diagnosed on.
Persistent beta HCG levels.
Correct. Now, again, a very important chart for your follow-up of molar pregnancy. Very, very important chart. I want all of you to have your attention over here. Now, a complete molar pregnancy, you're going to do suction evacuation. Following that, you're going to do beta HCG 48 hours after evacuation. If that's falling, how you're going to monitor the beta HCG? You're going to repeat beta HCGs 1 to 2 weekly serum beta HCG. Okay. Now, after 1 to 2 weekly serum beta HCG, there are two ways your follow-up can go. The first follow-up is if your beta HCG has normalized less than equal to 56 days after the evacuation, you are going to measure urine concentrations of beta HCG monthly for 6 months from the date of evacuation. Okay, try to understand this. Okay, the next part is, if the beta HCG normalizes more than 56 days after evacuation, you are going to measure urine concentrations, that is serum beta, the urine beta HCG levels or urine pregnancy test, monthly for 6 months from the date the beta HCG becomes normalized. Okay, are you people following that? If it is 56 days, 55 days, and 54 and thereon, you're going to do urine concentrations monthly, 6 months from the date of evacuation. Imagine somebody in January, 1st of Jan, had a complete molar pregnancy, did a suction evacuation, and somewhere on 15th of Jan, or maybe 2 weekly, you're monitoring, and after 4 weeks, like 1st of Feb, okay, it normalizes. After 4 weeks, it's normalizing. The beta HCG is normalizing. So how are you going to take this forward for the follow-up? Anyone?
It is less than 56 days. So it is normalized in 1 month.
Correct.
So we will do urine concentration every 6 months because date of evacuation was 2nd of January.
Correct. Monthly. We are not going to do every 6 months. We are going to do monthly.
Monthly
So
for
it will
6 months.
Yeah, monthly for 6 months. Okay. Now, same patient, the normalization of the beta HCG happens by end of maybe
February.
mid-March or end of February.
Mid-March.
So how you are going to do it?
You do monthly HCG tests for 6 months from the end of March.
From
So
March. From
yeah.
end of
Correct.
February, first week of March.
Correct. Perfect. Easy?
Yes.
Easy. Easy. Correct? Now,
So we take it as date of beta HCG normalizing if it is more than 56 days of evacuation. Means beta HCG normalizing after more than 56 days.
correct. Please
And
remember this.
and it is less than 56 days normalization, then we take date of evacuation.
Correct. Please remember this. In a lot of GTG guidelines, very notorious, they'll always give you these numbers. 56. 56 is given in both the boxes, but 56
Both the boxes.
and less than 56 is where you're going to do from the date of evacuation. Anything up, like 57 and up, you will do 6 months every monthly.
From the date of normalization of beta HCG.
Okay, but 56, if they are giving you 55 days, 54 days, that's fine. If they give you 56 days, it's going to be from the date of evacuation. Okay, remember
Evacuation.
that. Remember those numbers. Okay. Okay. Now, one more thing. If in your SBAs, if you have both the options, whether 1 weekly or weekly serum beta HCG or 2 weekly beta HCG, please select 2 weekly beta HCG. Okay, just remember this. Okay, again, everybody clear about this, because follow-up of molar pregnancy is very important. It's very different from the complete mole. Okay, any doubts on this, if at all? Simple slide. Okay, should I move on to the next? Yeah.
Yes.
Yeah. Okay. Okay, again, a very important slide. Now, this is the follow-up for a partial mole. Now, the follow-up of partial mole is very simple. Follow-up is concluded when HCG is normal on 2 samples, at least 4 weeks apart, okay? Even if they are less than 56 days, more than 56 days, that is not concerned with this, okay? Okay. Partial mole follow-up is concluded when HCG is normal on 2 samples at least 4 weeks apart. Okay. This is how the follow-up of partial mole goes on. Okay. Clear? Complete mole is different. This is partial mole. Its follow-up is concluded only when HCG, like you imagine there was a surgical evacuation on 1st of Jan. Okay. you're doing HCG. Okay. By end of Jan, one is normal. Okay. By take it like 24th Jan or end of Jan, it's normal. 30th Jan, just 15 days we are counting. HCG is normal on 30th Jan. What is your next step?
HCG after 1 month and then conclude. 4 weeks.
Yeah. And then that's when you will stop the follow-up for partial. Okay. Got the difference between the partial mole and complete mole? Yes. Yeah. Okay. Now the other box which says women who have not received chemotherapy. Okay. Now this comes from, this is an update from a 2010 guideline, which was the guideline which was of GTD, where it said that when the patient has come out with a successful pregnancy outcome, like she has a history of a complete mole in her previous pregnancy. This time she has conceived, she has delivered a child term baby. How are you going to manage further? So the previous guideline said that she need to have her HCG measured. Okay. But the new guideline, which is the 2020 guideline, says that women who have not received chemotherapy, okay, after any mole or complete mole or partial mole, do not require to have their HCG measured or the histopathology of their placenta after any subsequent pregnancy event. Okay, you're just going to have a normal follow-up of the pregnancy, post-pregnancy. Okay, nothing special needs to be done. Again, one of your questions in your EMQs or even one of your practice books, वहाँ पे answer गलत है. The answer is wrong in that book, but it needs to be corrected, where you're going to choose that you don't need any follow-up. I have included that EMQ in this. Just remember when you're solving that. Okay. Okay. Now this question, who would like to try? Anybody? USG in a 30-year-old woman revealed complete mole. Okay. She's told that complete mole was there. Now we know complete mole, partial mole. We are going to the complete mole chart. Okay. She was managed by surgical evacuation, serial beta HCG monitored. It reverted to normal 4 weeks after the procedure. So 4 weeks after the procedure, it's reverted back to normal. She would like to know how long she would wait before the conceiving. All patients, either of complete mole or partial mole, are
I think it's
advised
E
not to conceive.
for 1
Continue.
year.
1 year. 1
1
year.
year.
Why 1 year?
I think that's what we advise them here in the UK. We tell them not to try out before 1 year. But I don't know if that's the guideline.
The guideline says she should wait for 1 year before trying to conceive. Okay.
I'm
The
not sure if
guideline
it's a
says.
guideline, but I know that our advice here is wait a year before you try again.
Mm, hmm. Okay. The follow-up for complete mole or partial mole, it says the patients are, your GTG says, okay, that the patients are advised not to conceive until their monitoring, their follow-up is complete. Okay. Uh, when the 1 year comes, I will tell you when you're supposed to choose 1 year also. Now let us go back to the question. It has reverted to normal 4 weeks after the procedure. So 4 weeks is how many days? It's 28 days. So she's going to.
Yeah, but I think
Mhm.
d- following what you just explained to us in the previous slides, the answer on this should be C.
See?
C. So because she's had a complete mole, right?
Yes.
So she has to test monthly for 6 months
Post the
post.
evacuate.
Yeah, that's a follow, and then that's completed the follow-up.
Yes. But 1 month is already complete.
Oh, you count that month. Okay.
Yeah, we count that. Yeah. So then it becomes
B.
the 5 months. Correct. Okay. If at all, I'll just change the question. If at all, I'm telling the complete mole, she had a complete mole. Eventually, she had to undergo chemotherapy. Okay, post complete mole. Okay, then how long she would have to wait? Then your answer would be Dr. Ken's.
That's when you do the 1 year.
Perfect.
Right,
Okay.
right. Yes. Okay. So, yeah.
Perfect.
Yeah.
Perfect. Okay. Okay.
Yeah,
Yeah.
it's true. A few weeks ago, I had to give methotrexate to someone, and the advice was 1 year after completion. Yeah.
Yes.
Okay.
Okay. Now you're clear. Hello.
Yes, so
Yes, thank
after
you.
chemo, it is 1 year.
Correct.
And everywhere else, it is the 6 months rule. And partial mole, when we are saying 4 weeks apart, she has to check beta HCG, then when would you advise her also we should say 6 months?
No. The answer is for complete mole, you understood the guideline 6 months. Okay.
6 months,
For
yes.
chemotherapy is 1 year wait.
1 year,
For
yes.
partial mole, it is 2 beta HCGs, which are normal 4 weeks apart.
4 weeks apart.
After that,
After that,
she can
okay.
conceive. She can.
After that, she can conceive.
Again, why? Because GTD, GTN developing after complete mole is at a higher risk, or almost a higher percentage, requiring chemotherapy, again 13%. Post that partial mole, it's only 0.5%. So that's why the
That's why.
monitoring for complete mole is more
More.
great. Yeah.
Hmm.
Yeah. Yeah.
So
Okay.
here you said reverted to normal 4 weeks after the procedure. That's why we are taking the 5 months option.
Correct. Yeah.
So this is 1 month
Because
and this
we
is
are going
5
to
months.
monitor because we are going to monitor 6 months after the surgical evacuation. No? So 1 month
Six
is
months
already
after
complete.
surgery. So 1 month is this 4 weeks, and then the option would be 5 months before trying to conceive. That's why we are taking B and not C.
Yes. Now, again, I'm shifting the question for you. Please, Dr. Kens and Dr. Vaisha, ma'am, all both of you, listen to the question very clearly. USG in a 30-year-old woman revealed complete mole. She was managed by surgical evacuation, serial beta HCG monitored, reverted to normal. Okay, reverted to normal after let us say 9 weeks. So now your answer will change. I think there is no option over here, but it will be
No.
beyond those 6 months.
It'll be monthly tests for 6 months from the
So it should be 4
normalization.
months because we almost finished 2 months.
No, but her HCG only normalized
More than
after
56 days. Yes.
So it's from the date of
Yeah.
So
normalization
date
of
from
HCG.
normalization of beta HCG. Correct. Got it.
So your answer would be C.
Hmm.
You have more than whatever another 6 or maybe
More
more
than
7 8
months.
months.
Yes.
Okay?
Yes.
That will change.
Hmm.
Okay. Okay. Clear about the follow-up of complete mole, partial mole, and mole with GTNF chemotherapy is required. I think
Yes.
whatever questions you're going to get from these scenarios only. Okay. On the very last day of your exam, you must have only 15 minutes for this guideline and you should be done. Okay. If you are clear with the concepts right from day one. Okay. May I move next? Yeah. Everybody, I
Yes.
mean, all of you comfortable with this question?
Are we going to get this recording for ourselves to study?
Mm, I think so. It is going to be available online. Yeah.
Okay.
And I don't mind if you want to click photos of the slides. I'm perfectly okay with that.
Okay.
If you want to do that. Okay. Yeah.
Okay.
Okay. Now. Okay. Next question. A woman has evacuation.
She starts somewhere. Beta every 2 weeks until serum HCG. Serum HCG after 4 weeks.
Oh, you want me to go back to the slide of partial mole? It's partial mole.
So it should be she needs 2 tests 4 weeks apart.
4 weeks apart. Yes.
Correct.
So
If it was complete mole, the answer would be what you said, Dr. Varsha, ma'am.
Mhm.
Beta HCG every 2 weeks.
Mhm. Partial
Okay.
mole. So every 4
Yeah.
weeks. Every 4
Yes.
weeks.
Yeah. Okay.
So that is C, right?
No. Partial mole,
It's
you
B.
monitor beta HCG in any mole every 2 weeks. But when it is concluded, it is every 2 weeks until levels are normal, followed by one confirmatory normal urine sample after 4 weeks. This answer is more complete for the partial mole.
Serum
Okay.
beta HCG and urine HCG every 2 weeks until levels are normal, followed by one confirmatory normal urine sample after 4. It was right 4 weeks apart, no? 2 samples. That is what it said, no? The GTG.
Hmm. Mm-hmm.
Not every
Yeah.
2 weeks.
No, beta HCG monitoring is every 2 weeks. But when is the conclusion?
Okay. I didn't get it.
This answer,
Okay.
this answer is more complete in the context of partial mole. Your answer which says serum beta HCG test every 2 weeks is also okay. But this answer, the reason why they have given partial mole, as I said, in the RCOG format, every word has its own importance. Because they have mentioned over here partial mole, this answer, serum beta HCG and urine HCG every 2 weeks until levels are normal, followed by one confirmatory normal urine sample after 4 weeks. Okay, so this answer is more complete in the context of partial mole. Okay, am I clear?
Little confusing.
Little
So,
confusing? Okay,
yes.
so later on, I do have a chart in the ectopic when I'm doing that. I have an entire follow-up chart where I mention the follow-up for partial mole, follow-up for complete, follow-up for ectopic, PUL, and everything. Okay,
Okay. Okay.
understand this. Keep serum beta HCG or urine HCG is every 2 weeks until the levels are normal. The only conclusion of the follow-up for partial mole and the complete mole is different.
So, beta HCG and urine HCG every 2 weeks is for all.
Any ha.
Okay. Okay.
The only thing is you are not having this rule of 56 days for the partial mole.
56 days wala rule is only for the complete mole.
Correct.
And serum beta HCG, urine HCG every 2 weeks is for both until levels are normal, followed by this is for 4 weeks. Conclusion that treatment is complete.
Correct.
That is what it means. Okay.
That is what it means. Okay. The conclusion for a complete mole is 6 months after the date of evacuation, monthly urine HCGs. Okay. Okay. 6 months, monthly, 6 months after the date of evacuation, if it is less than 56 days. More than 56 days, it's 6 months from the date
6 months from the date of normalization of beta
of the
HCG.
HCG. Yeah. Okay. While for
Yes.
partial mole, this is complete. Like you are doing serum beta HCG and urine HCG levels every 2 weeks until the levels are normal, followed by
And then followed by one after 4 weeks.
4 weeks. Yeah. That's when you're concluded that this patient does not require any more follow-up.
More follow
Okay. That's where her follow-up ends.
ends. Okay.
Okay. Okay. If it would have been complete mole, the answer would be incomplete, but still I would choose serum beta HCG test every 2 weeks. Okay, which I just mentioned in the chart. Okay. Okay, clear? Now clear?
Yes.
Yeah. Again, uh, the recommended interval between a complete mole / partial mole and trying to conceive. Women are advised not to conceive until their follow-up is complete. The GTG says that. Post chemo, do not conceive for 1 year after completion of chemo.
Chemo.
Yeah. So complete mole, 6 months from date of evacuation or the date the beta HCG normalizes. Okay. Partial mole, 2 beta HCGs, 4 weeks apart. And chemo, it's 1 year after the chemo. Simple. Okay. Just remember this. I think majority of your questions would be solved. Now, Monitoring of women, again, which I had just mentioned, this was your previous guideline in 2010. But the 2020 guideline says that women who have a pregnancy following a previous molar pregnancy, which has not required any treatment for GTN, that means which did not require any chemotherapy, do not need to send a post-pregnancy HCG sample, and the histological examination of placental tissue from any normal pregnancy thereafter, after a molar pregnancy, is not indicated. Okay, so you are going to have a follow-up of such a such a postpartum female who just delivered normally, but she did have a history of a complete mole without any requirement for chemo. She's just going to have a normal follow-up. Okay, nothing special to be done for her. All right. Okay. Again, how is twin pregnancy of a viable fetus and presumptive coexisting mole managed? Sorry. Women diagnosed with a combined molar pregnancy. Again, upcoming slides for twin pregnancy. Again, good to know. I wouldn't say must know for me, just good to know. I think there is one question in one of the practice books which talks about a twin pregnancy with one mole and the other one a normal pregnancy. Okay. Now, women diagnosed with combined molar pregnancy and viable twin, or where there is a diagnostic doubt, kindly refer to the regional fetal medicine center and GTD center. In the situation of a twin pregnancy where there is one viable fetus and the other pregnancy is molar, the woman should be counseled about the potential increased risk of prenatal morbidity and the outcome for GTM. Prenatal invasive testing for fetal karyotype should be considered. Please remember, should be considered, already given by the GTG, in cases where it is unclear if the pregnancy is a complete mole with the coexistent normal twin or a possible singleton partial molar pregnancy. If at all there is a confusion whether it's a partial molar pregnancy or there is a complete mole with a coexistent normal twin, this is the option you're going to choose: prenatal invasive testing. Okay. Prenatal invasive testing for fetal karyotype should also be considered in cases of abnormal placenta, such as suspected mesenchymal hyperplasia of the placenta. Okay, just theory. Now, what are the complications? There is an increase in a twin pregnancy of fetus and a coexistent molar in early fetal loss, premature birth, and preeclampsia. Histological examination of such a twin delivery of placenta is recommended, and all confirmed cases of GTD should be registered with GTD center. Okay, risk of GTN and chemotherapy outcome remains unaffected after such a twin gestation. Now, suspected ectopic molar management. Please remember this. It is to be managed as any other case of ectopic pregnancy. You will have to follow up. You have to follow up, or you have to manage it according to your GTD guidelines for the ectopic, or the NICE guidelines for your ectopic. Okay. Now, what is PSTT and epithelioid trophoblastic tumor? Again, for me, this is just good to know. Hardly any questions coming from this, but this is, even if you just know the slides about it, I think you should be fine. All PSTTs, the placental site trophoblastic tumor and epithelioid trophoblastic tumor, are registered and cared for within GTD center. Again, an SBA which comes, which of the following needs to be referred or are to be registered with the GTD center. I'll just share the slide with you all. Localized disease requires hysterectomy. If there is a long time period since the antecedent pregnancy and or there is distant or extensive meds, you're going to choose chemo. Now, atypical PSN, that is the placental site nodule, has a strongest link to cancer. Again, treatment, hysterectomy. If an atypical PSN, you need central reviewing. If it's a typical PSN, you do not require any further investigation or review. Okay, now why this slide is important. Now, what are the GTD centers? Again, a very simple SBA. The GTD centers are your London, Sheffield, and Dundee. And what are the cases which needs to be registered and require follow-up as determined by the screening center? An important SBA for you. Remember this: complete molar pregnancy or any partial molar pregnancy, you're going to refer. Twin pregnancy with complete or partial molar pregnancy. Limited macroscopic or microscopic molar change suggesting possible early complete or partial molar pregnancy or choriocarcinoma. PSTT or ETT, and a typical PSN. Remember, typical PSN, as the previous slide said, did not require any reviewing. So typical PSN need not be registered, do not require follow-up. Remember this slide, two SBAs from this slide. Okay. Now, again, PSTT and ETD management, the most important prognostic factor for adverse outcome is the interval to presentation from the last known and presumed causative pregnancy. The interval is set to 48 months. So if you have like stage 1 PSTT with previous antecedent pregnancy, the causative pregnancy less than 48 months, please choose only hysterectomy. If you have the stage 1, the hysterectomy, but antecedent pregnancy is more than 48 months prior, you will have to choose hysterectomy plus intensive platinum-based combination chemo. Okay, agree? I mean, easy. Any doubts regarding? I think this is just good to know parts from your GTG, which I've just made it into a concise part. You can just go through these slides when you're revising. Okay? Okay?
Okay,
Hello?
okay.
Yeah, okay. Now we are coming to the FIGO scoring. Again, if you have read the GTG guideline, the table is pretty overwhelming, but let us make it easy. PSTT, ETD, best treated by surgery, less sensitive to chemo. So they are not managed by the FIGO scoring. Rest all GTNs are going to be managed by this. Single agent, multi-agent determined upon the FIGO scoring. Okay, so almost coming to an end. Do you people want to take a break of 5-10 minutes?
No, you can go on.
I can go on?
Yeah.
Okay, yeah. So again, a very important table for your SBAs, EMQs, a lot of questions, recalls will be coming from this table. Now, they will give you a scenario, they'll give you information, sometimes more, sometimes less. And then how to remember this? First stage of the patient, remember 39, 38. Okay, can everybody listen to me, hear me? Hello?
Yes, yes.
Hello? Yeah? Okay. So age, less than 40. If it is 36, 37, 38, 39, it's going to be a 0 score. If it is 40, 41, 42, it's going to be score 1. Always remember that. Less than, always, when you're seeing the figures, always see in GTG whether it is less than equal to or whether it is less than, okay, or it is whether it is more than equal to or it is just more than, okay, because this can get tricky over here. Then antecedent pregnancy, mole, score goes 0. Abortion, including a miscarriage, score is 1. Birth, a term birth, any birth, the score is 2. There is no 4 scoring for it. I always remember it as MAB, okay? Mole, abortion, birth. I always remember it that way. Now, interval months from end of an index pregnancy to treatment. Index pregnancy is the pregnancy in which the GTN has happened. So if it is less than 4 months, if it's 3, 2, 1, you are going to score it 0. If 4, 5, or 6, it's going to be score 1. If 7 up to 12, it is going to be score 2. 13 or equal to, more than 13 or equal to is going to be 4. I remember it this way, index 4, 7, 13, okay? But again, you can have your own ways to remember this table. You'll have to mark this table up. Easy, it can be done easy with your own ways, okay? I had this way of doing the table. Pre-treatment serum HCG, I did it this way, HCG, 3 letters. So the first scoring starts from 10 raised to 3, less than 10 raised to 3. The second is 10 raised to 3, less than 10 raised to 4, 10 raised to 4 to less than 10 raised to 5, 3, 4, 5, and more than equal to 10 raised to 5. Now the largest, the fifth part is the largest tumor size, including the uterus. If it is less than 3 centimeters, 3 to less than 5 centimeters, more than equal to 5 centimeters, and 4, there is nothing 4 score for this. Size of, I think it's the site of Mets, lung, because now there is one more SBA which I came across. I've not included in this. Again, the most common site of Mets for a complete or for a GTN following a complete mole, lung. Okay, because it's the most common, the scoring is 0. Okay. The spleen, kidney, score 1. Gastrointestinal score 2. Liver and brain score 4. Number of Mets. Number of Mets, remember, 1 to 4 5 to 8 and more than 8 is 4. Okay. Any previous history of failed chemotherapy, it's going to be single drug, scoring is 2. Two or more drugs, scoring is 4. Now, I would recommend that you have a small folder which has all the tables when you start revising or when you start going through GTG. So you put all your tables over there. So you keep on revising just as you're going to revise your incidences, you keep on revising your tables. After you have scored this, if the value comes 6 or less, it's going to be a single agent therapy. If the score comes 7 or more, it's going to be a multi-agent therapy. All right. Okay. Let's go to the next slide. Minute. Yeah. Single agent. Okay. Am I clear? Hello. Hello.
Your voice is
Hello.
cracking. Hello.
Am I audible?
Yeah, voice was
Can you hear me
cracking.
now?
Now it's okay. Now it's okay. Yeah.
Now it's okay? Yeah.
It's
Okay.
okay.
So if
Okay.
there is a single agent, again, the entire, I have compiled the entire chemotherapy regime for you. So you just have to go through this slide. Single agent methotrexate, if it is just 6 or less than 6, is going to be single agent methotrexate, alternating daily with folinic acid for 1 week and then 6 days rest. Okay. Treatment is continued in all cases till beta HCG has turned to normal, plus further 6 consecutive weeks. Okay, remember that whether it is single agent or multi agents, it's the same. Okay, if it is 7 or above, it's going to be a multi agent therapy. Remembering these drugs are important. Okay, because one of the questions, I have an SBA and a EMQ which does address this part. The way I remember it was like IMACO. Okay, I think in lot of medical oncology people, they remember this way, the IMACO. So E is for etoposide, M is for your methotrexate, A is for actinomycin. I have made it deactinomycin, so actinomycin. C is for cyclophosphamide and O is for oncoverin. Vincristine is also known as oncoverin. Okay, just for you to remember, IMACO. So IMACO is the multi-agent therapy for your GTN. Okay, right. Now again, this is good to know. Choriocarcinoma, extensive investigations, which shall include CT chest, abdomen, MRI of head and pelvis, HCG, Doppler USG of pelvis. Again, if the score is 13 or higher, it is a very high risk, and it just has a prognostic this of maybe death within 4 weeks. Again, good to know, not that important. What I want you to remember is this table, which is less than equal to 6, more than equal to 7, and treatment is continued in all cases till beta HCG has turned to normal, plus further 6 consecutive weeks. Okay, now we are going to solve a few questions on this. The table. Okay. Do you want to attempt this question? Anyone of you?
41-year-old died with GTM 6 months after. Single lung meds. "41-year" means it will be 1 age. Then
Do you want me to
15,000
go
is,
through the next slide? The previous slide? Yeah.
so she's 41-year-old. So score will be 1 plus she has undergone I think it was a mole, right? Antecedent pregnancy. So it is
A complete mole.
highlighted, complete mole.
Hmm.
So it is 0. So 1 plus 0. Beta HCG is 15,000. So it is 10 raised to 3. More than 10 raised to 3. So it will be 1. So 1 plus 1, 2. And she has a single lung. So site of lung is 0. So she has a score of 2.
No, एक minute. She has 6 months from the antecedent.
The 6 months from the antecedent. So that is again 1. So score is 3.
1, 0. 1 and this 3 and 0. Yeah.
3.
Hmm.
So she has a score of 3.
Hmm.
So you don't give her key.
Huh?
No, less than 6, you'll get a single.
Ah,
Single.
exactly.
So you'll give her single dose.
Correct. So you have the
Single
option.
drug.
Okay. So
So
what are the
I
options?
am.
What are your options?
So it will be. We have to. Multi-agent is out. So D and E is out.
Okay.
So
Yeah.
now I am methotrexate alternating daily with folic acid for 1 month, followed by 6 days rest until HCG has returned to. So it will be, I think, C.
Correct. Okay. Because
And
the first says
alternating
6 consecutive
6
months.
consecutive months, further
That
6
one.
months, and this
Yes.
is further 6 consecutive
Two
weeks.
weeks. Correct. So it's C. Okay. Easy.
Yeah, got it.
Got it. It's like maths. You
It's
just
like
have to do one
maths.
thing. It's like maths. Okay. It's absolutely
Yes.
like maths. Okay. Once you get the knack of solving questions simultaneously with the GTG, then you know what to
But
read.
how do we, where do we get these questions along with the GTG? We'll have to hunt them in the books, right?
So all your books, majority of your books have topic wise. There are few books which have complete papers. Okay. So, but
Okay,
the
so
majority of
topic
your
wise
books,
would be better.
yeah,
Can you suggest those books?
I will just put in a message or something. I'll just have to search those
Okay,
books because
okay.
it's they're ready with me.
Because
Uh,
topic wise, it is much better to solve and
I'll tell you what I did during my preparation. I had
hmm,
all the books in the PDF format. I have absolutely studied all the books electronically. So
hmm,
whenever there was a first page of the book, the opening page, I have written over
hmm,
it. It's
hmm.
topic wise. This is paper.
Okay.
This is topic wise. So when I'm
Hmm,
solving, when I'm doing the GTG and then I'm
hmm,
solving the questions, I always
hmm.
went to the topic wise books first. Okay. And
Okay.
I solved them. Okay. Because it's easy.
Hmm,
And
hmm.
the rest of the books which were papers, sometimes I left it for doing it later on when I was doing all the papers. Sometimes I did search because on PDF it is easy if you have electronic, the digital format of the book rather than having the hard copy.
Okay. So if you
So
can suggest the name of the book, we can buy it, or it will be available in the
I
course
think
in
it
the
will be
PDF.
available with the course material, most probably.
Okay. Okay.
Okay. Yeah.
Okay.
Okay. Again, this is an EMQ format. Okay. Mm, hmm.
21-year-old woman attended hospital 6 weeks amenorrhea.
I will just not do the first question. Huh? Just don't do the first question. Do the question number 11. The 11th question.
Number 20, we attends 15% plus serum beta HCG as example.
Just do it. A 21-year-old woman attended the hospital at 6 weeks of amenorrhea and a positive home pregnancy test. A likely miscarriage was diagnosed on USG. She opted for surgical evacuation. The product of conception demonstrated was partial H mole. Okay. We'll leave that question for later on. The same 21-year-old woman reattends the hospital 15 weeks later with a persistent vaginal bleeding. Her serum HCG has risen to 6,000. What is your management? What is your further step? Next step.
Refer to GTD
Refer
center.
to, yeah.
For the second this refer to GTG directly. Would you like to do something else? This question is a partly incomplete question. Okay. They have never mentioned whether the beta HCG came to normal or whether it didn't. Okay.
Because if it's a GTN, we have to refer her.
Absolutely. Absolutely.
So
But
then the answer would be refer to local specialist center.
correct. Correct.
it wouldn't be tertiary hospital, right?
No,
It
it wouldn't
would
be
be
tertiary.
it
Yeah,
would be referred to local specialist center. If it is a persistent rise in HCG.
correct. But how do we know? What is that step in between? Because
Creatine.
they have not mentioned whether it became normal or it didn't. They are saying persistent vaginal bleeding. So the step which is there, the immediate next step, which you would like to do?
Ultrasound?
Correct. Correct. Absolutely correct. So that's going to be the answer. You need to do the ultrasound to understand if it's the same thing or whether it's altogether a new pregnancy. Okay. Don't you want to
Mhm.
do that clinically?
Correct. But there's
And
no,
that
is there,
option,
there is no option here.
it is the R option.
Ours.
Oh, the last one. Oh, it's off my screen. Okay, okay, okay.
Okay.
Yes, yes.
Okay.
Okay.
Okay. Yeah. That the in between step. Okay. Of course, you are all right because it is persistent vaginal bleeding, 15 weeks later, serum HCG very high. But the most next step would be the USG scan. Okay. And then if that also comes with written products of conception or something like that, then you're going to refer to the GTD center. Okay. Clear about this question? Again, one of the questions from your EMQ practice books. Okay. This was the question which I thought, I'll tell you the question. One of the question in this needs the correction in the book. I think it is Kamlesh Gupta and Chinmay Datha's book. I think it's that. Okay, let's all go on to the next question. I'm just skipping the first question. I'm just not completely sure, completely satisfied with the answer. That's what I will. We'll redo the question once again when we are doing it in a recall or when we are doing it in the practice session. Okay, go on to the question number 12.
43-year-old multiparous woman diagnosed GTN 3 months following surgical termination. Her serum, she has small 1 centimeter mets in the lung.
Do you want to refer to the chart? Should I keep the chart open?
43 is 1.
Hmm.
Then 3 months following is 0.
Correct.
Then serum HCG 10 raised to 3 is 1. And
Correct.
lung is 0.
Correct.
So she is 1 plus 1. She's less than 6. So it is a single drug.
Correct.
Methotrexate and folic acids. Polinic acid.
Polinic acid, yeah. You're correct. Next question.
24-year-old multiparous woman diagnosed with GTN 6 months following partial mole and has a single 6 centimeter mets in liver. Liver was 3. 6 months is more than 4 months. It's 1.
There is
Plus
no
1,
score 3, by the
4.
way.
Pardon me?
There's no score 3 on the table.
There is no score 3. So liver is 3?
No. Lung, brain, liver, GI. 24, 20, say less than
Lung.
40. 0, 6. 6 months is 1. Single mets in the liver is 3. So score is, anyway, it is less than 6.
Are you sure?
Partial mole is 0. Less than 24 is 0. 24, less than 40 is 0. 6 months is 1. More than 4 months.
Hmm.
And single 6, I don't know which is the liver point. How
Liver
much
is
is the
4.
points for
Liver
the
is 4. Okay.
4? So 4 and 1, 5.
Hmm. What about this
5
single
plus 0
6
plus 0.
centimeter mets?
How many mets? Yeah.
Size of the mets. Largest you.
Size of the
So
met.
this is
Yeah.
5 or more is 2. So if
It's 2.
this question did have limited information, okay? But still,
Liver is
liver is
4.
4.
So it's a 4.
So
Number of met single will be also 1.
Correct.
So 4 plus 1, 5, and this. So it will go more than 6.
Correct.
So it will be multi-drug.
Correct. So what
So
is
Imaco.
yeah. So can you tell me what's the option?
So Imaco is the first one. Etoposide, methotrexate, CC.
Correct. C. Okay. Got it? Easy?
Yes. इसमें actinomycin, dactinomycin is actinomycin.
Actinomycin. It's just easy to remember that.
Yeah, Imaco, CO. Oncovarin is vincristine.
Oncovarin.
Oh, yeah.
Vincristine is oncovarin.
Yeah. Vincristine is oncovarin. Yes.
Just do it 5 times right now with me, and you should be all fine. You'll remember. You'll never forget it. Okay. Next question, Dr. Kens, would you like to attempt it?
Sure. 21-year-old primiparsa woman who's had a previous older pregnancy is not progressing well. So she's had a previous molar, but now has a normal pregnancy and is progressing well 1 year later. How would you manage her follow-up after her normal pregnancy?
Mm-hmm.
Wouldn't do anything.
Q,
Exactly.
treat her as normal. No?
Q, treat her as normal.
Treat her as normal.
Q, yeah.
Yeah. So this is the question where the answer is wrong. I think it's not wrong. It is based upon 2010 guideline in one of the practice books. Please correct it. Now it's going to be treat her as normal. Okay.
Yeah.
Okay. Okay. Clear with the follow-ups and management with FIBO scoring?
Yes, quite good revision. Yes.
Yes. Okay.
Yes.
I think if you just go through this, solve the questions, your GTG guideline is done. I'm very sure about it. Okay. Now, the next one, outcome. Now, few slides again, just good to know slides. Just remember it. Even if you're not able to revise it, that's okay. Okay. Risk of further molar is approximately 1%. Okay. 1 in 80 generally, but 1 in 100, fine. No increased risk of any maternal complications. Molar pregnancy, if the index pregnancy, if it is the index after the index pregnancy, 25% increased chance of the PTB. Preterm birth, and again LGA, last for gestational age, and stillbirth. Okay. Basically, if the previous pregnancy is molar pregnancy, the right now pregnancy is normal pregnancy, patient is going to have increased chance of preterm birth, LGA, and stillbirth. Okay. Now, simple question. Anybody would like to attempt it? Simple incidence question.
What person needed additional chemotherapy?
What percentage of women need additional chemotherapy? You have to tell the rate. What percentage? Should I go to the first slide of incidences? Would you like to see that, then answer the question?
Yes.
Yeah.
I think it's
Answer. I'm not able to exit. Can you give me now the answer?
So they were asking for complete mole and partial mole.
Partial.
So 15 and 5.5.
Correct. Okay.
So
Again, one of the
chemo rate.
SBAs. Yeah. Again, one of the SBAs from your books. Easy one question, easy incidences. Okay, I think we are
So we
coming
just have to
towards the
go through the file, all this once again. Then I think it's
Yes.
done. One GTG is
Your
done.
GTG is done. This GTG is done. Because I have made the PPT in that way. I don't want like it should be at one glance. You are done. You are done with this GTG. You don't have to revise it. You will be able to answer almost 90 to 95% questions. 5% questions, don't bother about it in RCOG exam, part 2 RCOG exam, because it's a lot. And frankly speaking, if you don't know it, nobody's going to know it. Okay, what you must know, what everybody must know, you must know it. I think the marking goes that way. Now, again, long-term outcome in GTN, just a few. Hello.
Sorry, sorry.
Long-term from GTN, that's okay. 83% chances of having pregnancy post single or multi-agent chemo. Menopause can occur earlier. 13% menopause occurs by 40 years, 36% by 45 years. No overall risk of secondary ulcers due to chemo. Okay, remember that. Again, good to know. Now, contraception post GTD and when to be commenced. I find contraception this is from the FSRH guidelines. Okay. Again, I have compiled it together so that once you're going to revise your contraception or you're going to do that module, you can again come back to this. But for now, with GTN, everything needs to be finished. Okay. Now, women should be advised to avoid subsequent pregnancy until the GTD monitoring is complete. Again, it's going to be, if you can revise with me, 6 months after the evacuation for patients whose beta HCG comes normal in 56 days, 6 months after the date of beta HCG normalizes, if for the patients whose beta HCG is coming normal beyond 56 days. For partial mole, two beta HCGs 4 weeks apart, and that's when you can plan the pregnancy. For anybody with GTN who has undergone chemotherapy, 1 year, you're going to wait, and then you're going to advise for conception. Okay. Effective contraception should be started as soon as possible, as sexual activity and fertility may resume very soon after the GTD. Now, again, this chart is important. What we have discussed previously, after complete molar pregnancy, women should be advised to avoid subsequent pregnancy for at least 6 months to allow human chorionic monitoring for ongoing GTD. After partial mole, it should be advised to avoid pregnancy until 2 consecutive monthly HCG levels are normal. 2 consecutive HCGs 4 weeks apart. Okay. Again, post chemotherapy, 1 year after the treatment is complete. Again, the same thing which we had revised before. It's the same thing again written in the FSRH, just a revision slide. Okay. Now, women should be advised that the most methods of contraception can be safely used, with the exception of intrauterine contraception, or the copper device or the uterine device. IUC should not be inserted in women with persistently elevated HCG levels or malignant disease. Now, IUC should not normally be inserted until HCG levels have normalized, but may be considered on specialist advice with insertion in a specialist setting for women with decreasing HCG levels following discussion with the GTD center. If at all you have a question where the patient is having a complete mole or having a follow-up of complete mole until the HCG levels, they are not normalized. But you must look out for these cues in the question where they say that the HCG levels are decreasing. It may be considered, this might come as a long EMQ or a SBA, where all these boxes need to be ticked, where may be considered. First of all, the thing will be considered, may be considered on specialist advice, in a specialist setting, following a discussion with GTD center. When all these boxes are ticked, that's when you're going to choose may consider use of IUC in a patient with HCG which has a decreasing trend. Okay. Otherwise, do not choose IUCD. Okay. As a contraception method in GTD. Only if all of these boxes get ticked, there is decreased HCG levels, following a discussion with the GTD center, specialist advice in a specialist setting, that's the time when you're going to choose, may consider or consider the IUC post GTD. Otherwise, that's not going to be the option you're going to choose. Clear? Hello? Clear? Hello?
Yes, yes, yes.
Yeah? Okay. This is easy. Is emergency contraception safe to use post GTD? Yes, takes place from 5 days after treatment for GTD. Women should be advised that the use of oral EC, oral emergency contraception, is safe after treatment for GTD. Hormonal contraception is all safe post GTD. Okay, insertion of copper intrauterine device may be considered. Again, specialist setting, decreasing HCG levels, discussion with GTD center. All these three criteria to be fulfilled, then only you can choose IUCD or copper intrauterine device for EC or whatever or normal contraception also. Okay. Now, is additional contraception required? Again, it's the similar for any EC. If it is immediately or within 5 days, no additional contraceptive precaution is required. If it is beyond that, additional contraception precaution is required. This rule applies for, I think, maximum of your emergency contraception with other methods of contraception that you will learn with the FSRH guidelines. Now, again, a small table. Again, hormonal contraception can be started immediately. Female sterilization generally not immediate, and as compared to female sterilization, patient needs to be always counseled regarding the LARCs, the long-acting reversible contraceptive, which is as much as effective, and it has a less failure rate as compared to female sterilization. When you're choosing barrier methods, again, diaphragm after 6 weeks, because the size of uterus will come back to normal after. IUCD, I've already told you, you have to check those three parts: decreasing HCG levels, a specialist setting, and a discussion with GTD center. If these three criteria are fulfilled, then only choose IUC insertion in patients post GTD. Otherwise, that is not going to be your option. Okay, clear on the contraception? Easy topic, but important, very important. Okay.
Okay.
Okay, then exogenous estrogen and fertility drugs, you can use them once HCG levels are back to normal. Now, the last slide, very important from your part 3 point of view, just to give an edge, what are the support groups available post GTD or post a loss of after molar pregnancy? Again, molarpregnancy.co.uk, and alongside regular drop-in support groups at Charing Cross Hospital, London, and Weston Park Hospital, Sheffield. Further information and personal and patient information leaflets are all available. This is just good to know point from your part 3. Nothing relevant for part 2 point of view. Now, the last slide, which I feel always used to make it after a GTG, after reading any GTG, I used to jot down what are the important points and what part of the GTG the maximum questions are coming. Questions may not be repeated, but the area of importance will be repeated. Okay. So first of all, incidences, which I have marked you for the slide. What are the main SBAs? What is the GTD and GTN definitions, the inclusions? What is the differentiation between the complete mole and the partial mole? Again, when we are considering regarding the karyotype, okay? The follow-up of a mole, complete mole, partial mole, and GTN, okay? Follow-up of all these three. Follow-up means includes the follow-up and when the patient can conceive. The FIGO 2000 scoring and its management. And lastly, the contraception post GTD and GTN. Okay. I think I conclude my session with this. Thank you so much for listening to me so patiently.
Amazing. Very nice. Thank you.
Thank you so much.
Thank you. Thank you.
That was a
Okay.
very nice
We
session,
can.
Dr. Dhanashri. Yeah. Very,
Yeah. Hi, Dr. Preeti. Okay, there.
yeah,
Okay.
yeah.
I
Very
did my
intuitive
best.
presentation. Yeah, yeah, yeah. It was
I did my best that after doing this PowerPoint presentation, you don't have to, many of the students does not have to go back and,
Hmm.
we just have to finish with this slides. They are
Hmm.
all done. They are set with the GTG.
Right, right. And this also gives this candidates an idea of how to go about the GTD. So guideline and all the other green top guidelines. So how to read the guideline, that is also very important, because sometimes we just keep on reading the guidelines, but we really don't know where to focus on. And the questions come from a very different area. So that is where the mistakes are made. So once you start reading a guideline, you should know where the questions are coming from, and how to remember them. Keep on solving the questions as much as possible, so that you keep on remembering the guideline, and you keep on revising the guideline with each question or SB or EMQ that you solve. And that is how it is, and it is always like practice, practice, practice. So it is never like once the GTD is done, it is done forever. So you have to keep on revising it every now and then. That is why we always say that part 2 is like very elaborative. So every guideline needs to be read like this only. And once it is done, you have made your own notes. I think there's a very less time that will be required for reading it for the next time. So it will be only revision. So, but with, I think with mentors like this, it is going to be very easy. Now, once you read your GTD guideline, it is going to be there for a very long time. And I'm sure now, after this guideline and after this session of this GTD guideline, people are going to be very happy with the session, and they are going to remember it for a very, very, very long time. It'll be easy for them to solve the questions. That is what I feel. I'm sure that both these candidates who are here, the other one left, I think, but both of them are from our part one course,
Mm-hmm.
and they have continued with us. So I'm sure that now the things have changed, isn't it, from part one?
Yes.
Yeah, so it is it. So things are actually easy because we being gynecologists now we know this. We are doing this every day, but the only thing is it is going to be very vast. That is the only thing. Otherwise, nothing is difficult or hard, isn't it, Dr. Dhanashri? It's just
Absolutely, absolutely. It just as you just read my mind. Just the portion with part two MRCOG is very vast. If you have the correct approach to it, as I just mentioned, and even Dr. Preeti said, it's just practice, practice, practice. You read the guideline once, you make your notes, you go back to solving questions, you again come back to the guidelines, understand from where the questions are coming, mark those topics that are important. The second revision is much easier. If you're taking one day to read a guideline this time, the second time you're going to finish it in an hour. By the time the third revision comes, like I said, 15 days prior to your exam, this guideline should go in like 5 minutes. You should be able to revise this guideline in 5 minutes, and you will be able. It just practice, practice, and more practice.
When are you planning to start the course? What date? And is it going to be weekly lectures?
Yeah, it is going to be weekly lectures like we did for our part one.
Okay.
And it will be mostly on the weekends. Of course, it will depend upon the candidates, the people who are coming for the course, where which day is preferable to them. So whether it is a Saturday or a Friday, depending on that, we'll keep it. And mostly it will start from the next week itself because I've got a few entries. They are not here for today's session, but I have already got a few entries for part two. So we'll start from the next week
So
itself.
it will be one GTD per lecture, right?
Now it is very difficult because there are almost 72 guidelines,
Correct.
which are main top guidelines.
Mm-hmm.
Then there are nice guidelines.
Mm.
Then there are
Then
talk.
how
So
do
it is
we, how
actually
my
very,
concern is, how do we know for which topic, which guideline to follow, NICE or GTG?
that will be given, of course, before we start with the module, like we used to give you in part one, what is to be read. So we'll
Okay.
be giving you exactly module wise what is to be read, what all guidelines
Okay,
you
okay,
need to
okay.
read.
So that you will tell us. So that
Yes,
is
of
not
course.
we have to sit and search. Okay.
No, no. Most of the times we'll give you unless and until there is something which is updated and we don't know about it. Only in that case, or a few things which gets updated recently in the last 15 days, and nobody comes to know about it.
Oh,
Apart from that, almost everything will be given. Even that will be updated maybe a little later after the session is done. Like we have finished our ANC module, and there's a new guideline that has come from the ANC guideline, which after finishing the session. So
okay.
of course that will not be
That
given
will be
in the
coming
previous
later. Yeah, yeah. Understood.
later. Yeah. So that is how it is. So, but once you are into this pool, of course, you will know everything, how to swim and everything. It'll be very easy. It's just like part one, like how you had doubts for your part one. You didn't know where and how to go about it. Once you are with other candidates and once you are into a course, there'll be always people who will be telling you how to do it. And after maybe a month or so, everybody knows then what is the syllabus and what is their method of studying. So actually,
Studying.
yeah, so it's like again it's self study. It is more of self
Hmm.
study. However lectures we take, like Dr. Dhanashri has taken it very elaboratively, like there's nothing that she has left, but still it is, you will still have to sit and read it once more and remember it, and only then you'll be able to solve the questions. If you just listen to the session and go to the exam, that is not how it is going to be. So
No.
self study is always there.
Yes.
We'll try to
Correct.
cover most of the guidelines as much as possible, but mostly it will be module wise. If it is a big module, there'll be two sessions of a module, because it is very
Hmm.
difficult to take these big lectures for one guideline, and people have time. Like in 2 hours you have finished one guideline, but you still have to read it. So if you read it
Correct.
once and come to the lecture and just do the important points, then there is no need of taking like these big lectures for every guideline. Then it will be
Yes.
easy.
No, you can give us homework that we should finish these two. So it becomes
Yeah.
compulsorily we read and come.
Yeah. So
And
that, yeah. So we
a
give you
lecture on
the
those two
syllabus.
or three guidelines together. Yes.
Right. So we
Maybe
always give you the
module wise. Yeah.
syllabus. Yes, yes. So there'll be some 4 or 5 guidelines in each module. There'll be
That
some
should be
talks in
nice.
each
Yeah.
module
Correct.
that you have to finish maybe in a week's time. If it is a big module, then you'll get little more time. Like we'll give you 2 weeks time. That's how it is. With the questions, maybe every
Yes.
alternate
You
every
can give
day
us
we generally give.
timetable. So we'll start
Yeah, yeah,
working.
yeah. Yeah, that is what I'm saying. The course is not for us to teach you, because you
Correct.
are gynecologists and we are also gynecologists. And
Correct.
in fact, you're senior to us. Maybe most of the people know a few things better than us. Maybe like I'm an infertility specialist, so I think I'm better with the infertility. Some other people must maybe better with obstetrics. So if I take a obstetrics lecture, I'm not teaching someone, right? So people
Right.
know everything. It's just scheduling people,
Exam point
keeping
of
them,
view. Yeah.
yeah,
Hmm.
yeah, scheduling them, keeping them
Hmm.
motivated, because
Hmm.
everybody knows also how to study. So basically it'll give you the syllabus, it'll keep you motivated, it'll keep you in the loop of all the updated guidelines also. And that's all. There'll be healthy competition along with the other candidates also. So that'll
Yes.
be the thing. That is the only thing that is required for exam. Rest all of
Yes.
us have cleared until now and will clear hereafter also. Right? Yeah, so Dhanashri, I think it was very good. I don't think there's any need of taking or rescheduling part two orientation session, because while the session was going on, we got a few entries, and I think we can start with our course from the next
Right. Yeah.
week itself.
Mm-hmm.
Yeah,
Yeah.
I'll put this uh, on all our medias, social medias, and our groups, so
Mm-hmm.
that other people who have missed the session can also go through the recordings. So that is also available in the course.
Mm-hmm.
If there's people are missing few of the modules, then they can also go through the recordings.
Okay.
Yeah.
Thank you so much for
So
giving me this opportunity, and thank you
um,
again staying late in the nights on a Sunday. Thank you, all of you. Yeah.
no, it was a great lecture actually. I did not wish to, but you kept me anchored to
Serious.
the
I
yeah.
loved interacting with people. I think Dr. Varsha ma'am and Dr. Kens, both of them were pretty into the lecture. I never even
Yeah.
felt they're just two candidates I'm teaching. It was like a one-on-one, and I don't know, it just went
Private
on.
tuition.
And good participation. Yeah, private tuition, good participation and good interaction. They were solving. They were consciously making efforts to solve the question. That's good.
Yeah.
And as I said, yeah, today is the first guideline. It did take me a bit long, but I have covered everything in the guideline. And
Yes.
as Dr. Preeti just said, I won't take much of the time, but generally it is that she would be giving you a timetable. So you have read the guidelines and then you're attending the lectures. So then you know what are the important points which you need to go back and revise. As she correctly pointed out, it is always a self study. We can just help you, we can motivate you, we can solve the queries, we can help you how to approach the emqs and sbas, because these formats are little bit different than the previous exams which we give. We can just help you with that, but eventually it's always the self study which is going to play a major part in the success in this
Please
exam.
give us those books, links to those books. Question, topic
Yeah, yeah,
wise
yeah.
questions.
I will be giving, no?
Yes, yes,
Like how
yes.
you
Everything will
gave
be
in,
available.
like how you gave in part one, no?
Yes,
Those
yes, exactly like that. Yes, it will be
PDF.
given for
Just give
part
us those
two,
books
for
because
part
they were
three.
very helpful. It was
Yes,
very
yes.
helpful.
There are a lot of books, ma'am. Don't worry. There are a lot of books, and everything will be
We
given to
don't
you.
need lot of books. We need how much to solve?
I was just going through my that Chinmay Ratha book because
Yeah,
I was making, and I realized, oh, I didn't solve these questions only for my exam. I
I
actually felt that,
know.
oh my God, I missed it. But
I
I
know.
think I could do my maximum at that
Yeah,
time.
yeah. So
But
it is
I
very.
just realized
There is
I
one more
didn't
tip.
solve. Yeah.
There's one just one last tip that I remember. I always tell it to all the candidates before starting part two is as soon as you finish reading your guideline for the first time, make your notes then and there. Your talk articles for the first time, make your notes then and there because it is very difficult to come back to those
Come.
notes. Yeah,
Mhm.
because it will
Correct.
be you
Absolutely.
have to finish a lot before coming back to those to
Those
those
talk
talks.
articles are accessible to associate members, right?
Yes.
Yeah,
Yes.
yeah, but
Yeah, yeah.
they'll be given in the course as well. That's
Okay.
not a problem. But
Mm.
you have to make it a point that whenever you are reading it, make your notes then and there itself.
So it's
Because if you feel
3 years, last 3 years, 5 years.
3 years to 3 to 5 years, there are few important ones also in the last 10 years,
So
which will
COVID-19 is the latest, I think, which has come. COVID-19. I just got the access today.
it
I
comes
re
every 3 months. It comes every three
so the
months.
last one is COVID-19 in pregnancy,
Okay.
Really.
So
January 2025. It's just
January.
come
Yes, January it
yesterday,
has come, just
18th,
come, just come.
18th Feb it has come. 18th Feb.
Yeah, yeah. So there are a lot of articles in the talks. Like there's
Hmm.
a talk, this is a journal, and journal has got a lot of articles. It's like that.
Hmm. So they have
So
given articles only separately access.
yeah, yeah. So we can
Hmm.
access it separately also, and as a
Hmm.
journal also it is available.
As a journal also. Okay.
Yes. So that is how it is. So make your notes then
Hmm.
and there, because coming back
Hmm.
to it is going to take at least 3 months, 6 months. Coming back to a module is going to
Hmm.
take a lot of time. So that is a very smart move to finish your thing there and there and make things available for revision, and so that time becomes a big factor here in part two. Yeah,
Yes.
so saying all that, I think we should say call it for a day now
Hmm.
and for a
Good
night, I
night.
think.
Good night.
And yeah, good
Right.
night.
Thank you
Yeah.
so
Good
much.
night. Good night.
See you in the coming
Yeah, good night,
lectures.
pleasure. Good
Bye.
night,
Congrats,
Mama.
Ken.
Thank you so much. Congratulations to you too.
Yeah, thank you.
Thank you.
Yeah.
Okay.
Okay.
Bye. Bye.